Well, good afternoon and welcome to today's 3M Health Information Systems webinar. My name is Lisa Martin and I will be your host. Joining me today as our moderator is Ryan Hansen, Segment Marketing Manager with 3M. We appreciate everyone's attendance today. In today's webinar, we will discuss the best practices that you can follow to create a successful denials prevention and appeals strategy program. We encourage you to ask questions throughout the presentation. You can do this by using the chat feature in the dashboard, which is located in the right portion of your screen. We are going to be recording today's presentation, and a webinar archive will be available after. Look out for an email within the next week that includes a link to the archive. A PDF that contains all of the presentation slides is available for you to download, and that's located in the handout section of your dashboard. We'll also provide a certificate of attendance to webinar attendees, and that will be emailed to you upon the completion of this webinar as well. Lastly, we very much welcome your feedback and value it, and ask that you complete the survey that will launch immediately after the webinar. Today's presenters are Dr. Beth Wolf and Sarah Bible. Dr. Wolf is board certified in internal medicine, palliative medicine, and clinical informatics. For the past 7 years, she has worked as the Medical Director for Health Information Management with Roper St. Francis Healthcare. She provides consulting services to 3M Health Information System and works to improve data reliability and align clinical documentation integrity efforts with physicians and system priorities. Sarah currently is a CDI Manager and Facility and Prophy Coding Manager for St. Luke's, a multi-hospital system in Kansas City, Missouri. Previously, she was the HIM director at multiple hospitals in Texas. Dr. Wolf, I know we are all excited to get started, so I will turn the time over to you.
Lisa, thank you very much. I'm very happy to be here. Clinical validation is something that oddly I enjoy doing. And interestingly, when I started working with CDI about 7 years ago, this was the first thing to land on my desk, clinical validation denials. And it's taken me a while to warm up to them. But I think that, for better or worse, they're part of our nearly daily routine. And I'm very excited to have with me today Sarah Bible from St. Luke's. I'll let her introduce herself in a moment. But I think understanding how real CDI and coders manage these is so very important. A bit about my hospital system. We're roughly 600 beds. We have now 4 hospitals, 2 larger and 2 smaller. And we pretty much do all services with the exception of organ transplants. And our CDI team reviews almost 100% of patients with the exception of OB, and we don't do pediatrics. With that, Sarah, I'm going to ask you to tell us a little bit about your hospital system to kind of put everything in perspective.
Welcome, everybody. Thanks for joining us today. St. Luke's Health System is in the Kansas City Metroplex, and we kind of sit in a unique area because we're both on the Kansas side and the Missouri side just because of where Kansas City geographically lies. So we have to follow Missouri rules and Kansas rules. If you guys have ever had to deal with 2 different states, it's definitely fun. But with our facilities, we have both sides of the state line with facilities, and we have 16 acute care facilities and critical access hospitals throughout the health system, which includes a little over 1,300 licensed inpatient beds. My team reviews, we do not review the critical access hospitals, obviously, but for the acute care facilities, we review every type of case with the exception of OB as well. We do not have pediatrics, so we don't even have the opportunity to review those, but we do review NICU cases. We just don't review the mom cases for those OB patients. We also tend to focus on, DRG payers, but we do actually look at self-pay stuff, self-pay patients as well.
Very good. Okay, so today's discussion is really going to be kind of a conversation, and I think that Sarah and I are going to talk about really how we have worked to determine the extent and composition of our clinical validation denials and how that's helped us standardize the appeal process. And kind of throughout that process, we ended up doing a lot of analysis on not only the payer, but our physician documentation and also our coding and CDI patterns. And I think, until you analyze your own patterns, it's going to be hard to kind of hardwire that prevention. So as we go through this, kind of keep track of your questions. We're hoping to leave a good amount of time for that. So for the folks who don't know what clinical validation is, very basically, it's the process of ensuring a documented diagnosis is supported by the clinical evidence. And that's significantly important and relevant. And for me, there are three reasons. And at the top of the list is integrity. And, I think that we have all appreciated that the administrative data, the codified data, is used historically to determine risk and reimbursement. But I think with the pandemic that we're seeing, it's also very evident that this data is used near concurrently to really help us figure out how to best take care of patients. And, again, that is so powerful and it's so important that we get it right. The second reason is compliance. And if you've not read the CMS conditions of participation, there is a portion that says claims submitted must not include diagnoses that cannot be clinically validated. So when I read that, I was like, well, of course, why would we put anything on a claim that isn't supported? And of course, in my learning journey, I had to realize that an unsupported diagnosis can end up on a claim. And the reason is that the official guidelines, as most of you probably know, tell us that code assignment is not based on clinical criteria used by the provider to establish the diagnosis. So we don't base whether or not we put a diagnosis on the claim as to how the physician got to that diagnosis. We obviously do have criteria for a secondary diagnosis, but frankly, it's a pretty low bar. Was it monitored or treated or evaluated, or did it increase nursing care or length of stay? So most conditions can be put into one of those categories. So it has become an issue. Now, the third reason that clinical validation is important, and it's the reason we're here today, is for reimbursement and denial prevention, okay? Again, we want to get it right, but we also want to make sure that we are making these cases as solid as we can in the documentation. So with that, I'm actually going to survey our audience. And the first question is, and we can go ahead and launch the poll. I have personally reviewed a clinical validation denial letter, helped investigate, or helped write a response. So any one of those three things. I've reviewed one, I've helped investigate, or I've actually written a response. So yes, no, not applicable, meaning I don't work for an entity that would receive clinical validation denials. And while we're waiting for those responses to come in, Sarah, do you want to talk about the first time you looked at a clinical validation denial letter, if you could remember that far back?
Yeah, it's been a while. But yeah, we were, used to getting coding denials, and we could look at it and it was pretty clear cut. Either we coded it accurately and we just needed to provide the support for why it was coded accurately, or we didn't code it accurately. It was pretty cut and dry. When we started getting these clinical denials, and I have both the coding and the CDI teams, which is very beneficial because you see both sides of their roles. But when we started getting these clinical denials, I'm not a clinician. We kind of, and our DRG coordinator, who does all of our appeals for us, she's also not clinical, and she is a coding guru through and through. But when we start gaining clinical stuff, that's definitely outside of her realm as well as mine. And so we spent a lot of time Googling things. And then I thought, well, why are we not utilizing the clinical team that we have with our CDI staff? So we made that transition with utilizing the CDI team for these clinical denials that we're receiving.
Yeah, I remember, again, my first experience, and sometimes it was a visceral response, but again, I've learned to approach them systematically. With that, do we have the results from our polling question?
We do. So 73% responded yes. We had 20% that responded no, and 7% that responded not applicable.
Okay, so I'm actually not surprised at that, Sarah. I think that more and more CDI are involved and coders in clinical validation denials. I do, for those who have not seen one, want to just describe typically what it looks like. So the first thing they tell us, this is what we are denying. Here is what we found in the chart. And of course, they pick out all the things that, they perceive do not support the diagnoses. And then in the body of the letter is usually a statement that says there was insufficient clinical evidence and supportive documentation in the records available for review to substantiate the coding of this condition. Therefore, the diagnoses will be removed or replaced with something else in the chart. So that's kind of the typical flow of the letter. So before we talk about the approach to clinical validation denials, I think, as we start to see more, I've always been curious as, kind of the number of clinical validation denials that come through each month. Sarah, do you have a sense of how many clinical validation denials your system is receiving?
Yeah, it's kind of payer specific. We usually receive anywhere from 10 to 15 per month. We can receive a lot less or a lot more, just depending on the payer's focus. But usually it's 10 to 15.
Yeah, I would say that's very similar for us. I'm definitely shielded. By the time they get to me, several eyes have been on them and tried at least the first appeal, and some of those we win. So I think that's probably a fair number for us as well. So regardless of how many you get, I think, the approach to clinical validations is an important concept to think about. And, where do you start? And for me, looking back, you always do things a little bit differently with perspective, but successful appeals and denial prevention, I think, requires an understanding of your particular hurdles. And although, some of them are very similar across facilities because we all have similar payers, I think that your analysis is still important to do. And that's looking at your pattern of denials from the payer, physician documentation patterns. Those can vary from institution to institution. Clinical documentation specialist query patterns. Standardization is something that we've worked hard to do, but I think, there's always work to be done with that. And then coding patterns. And I think you also need to appreciate, who needs to be involved, because this is a monumental process, and you have to involve really multiple disciplines along the way. And, again, the first for us was really engaging the revenue cycle with CDI and understanding who receives the denial, what department does it come to, and part of this is an inconsistency from the payer perspective, but some of it is just internal organization. And then, of course, what payers are involved in, and what kind of software are you using to track the denials or spreadsheets. The second thing that we often overlook is payer contracting. And, I think that, much like utilization review has a matrix of their payers and what their criteria are for an inpatient status, we really need to be doing the same for these clinical validation denials, meaning, is there a time limit? Is there a certain number of appeals that we have the right to? And when can we request a peer-to-peer discussion? And then if we still can't come to an agreement, what is our recourse as a hospital system? Because the payers generally hire a third-party company to do their audits. And so, there's layers of people involved. The next thing, of course, is us, coders and clinical documentation specialists. And, we're going to really be honing in on the particular diagnoses that are targeted and the clinical criteria that the payers are using. And then lastly, of course, our bedside documenters, the physicians, the nurses, the dietitians, they're the ones that really need to be developing the organizational consensus on criteria for these high value diagnoses. And then providing us feedback with regards to the documentation systems, because many times limitations are really being fueled by the electronic health record. Okay, so when I think about clinical validation denials, I like to kind of compartmentalize, and I think about, what is being denied and how it's being denied. And so again, the first thing that we look at is those targeted diagnoses. And, again, what's a targeted diagnosis? It's basically these high value diagnoses that, if removed, would reduce reimbursement. The payers are not challenging diagnoses that don't result in reduced reimbursement if they're removed. I'm going to move to the second polling question. And Sarah, I'm going to ask you as we get there to kind of think about what your commonly targeted diagnoses are and what trends you've seen over time. So let's go ahead and launch that second polling question. So the question is, what diagnoses do you see most commonly denied because of clinical validation? And I've listed some of the top ones here: encephalopathy, severe malnutrition, sepsis, acute systolic or diastolic heart failure, and then other. And if you have an other, go ahead and type it in the comment section, and I'll open that up here while Sarah kind of gives us some insight from her perspective.
So all of those diagnosis codes that you have listed there are very common at our facility. One other I would add to the list would be type 2 myocardial infarctions, as well as hyponatremia seems to be a new one that has been added to the list. As far as trends that we've seen, the payers are targeting those cases where there is a lone MCC or lone CC on the account, and it's a relatively short length of stay. Those are the main things that we are seeing. And later on in the presentation, I'll discuss some of the processes that we've put in place internally to help deter some of that lone MCC, CC, or lack of documentation to support that diagnosis on all of our cases.
Excellent, excellent. Do we have some results on the poll?
We do. So 9% said encephalopathy, 18% said severe malnutrition, 61% was the highest with sepsis, only 2% said acute systolic or diastolic heart failure, and 10% said other.
And are you able to see the comments? For some reason, they've escaped my screen. Did we get any write-ins on that?
I'm not able to see those right now. Let me see if we can pull those up somewhere else. Apologies.
Okay. Well, you can jump in with them if you see them. I think the bottom line is that we all share sepsis, encephalopathy, and severe malnutrition. But again, payers are, pulling out the stops on many others. And if we look at kind of those targeted high-value diagnoses, again, they're going to be CCs and MCCs, the complications and comorbidities and major ones. And I put this up here, and again, this sort of is tiered out on risk of mortality from minor to extreme. And again, these are several of the ones that we have encountered over the past 2 or 3 years. But I think it's important to note, right now, these have financial value because they're CCs and MCCs, but don't forget, when they're removed from the claim, we're also losing the risk adjustment. And again, as the country moves from a payment system of volume to value, it's these risk of mortality factors that are going to play into it as well. So again, we want to keep what's rightfully ours and fight hard for that. Knowing and following your systems trends will also allow you to focus your efforts on the most pressing issues and triage your resources. Many of us don't necessarily have the resources to fight all of these, or to address them all at once, but to tackle the ones that are the most problematic first is the right way to go. Okay, so in addition to the targeted diagnoses, I also look at the validation denial distribution. Okay, so we have valid. Okay, so when I read the denial letter and I go to the chart, I make an assessment, and valid is if the patient appears to have the condition in question, regardless of how well it's documented. And I appeal all of those. Again, if the goal is to have the record accurately reflect the patient, then valid diagnoses should be on there. I review charts, and I also find situations where the diagnosis was not valid, meaning the patient did not appear to have the condition in question, and I readily pay that back. And I use that as an opportunity to educate both the physicians or the extenders who wrote the diagnoses, as well as the CDI, who we are encouraging to and consider part of their job to validate those diagnoses. Now, within the valid category, from my perspective, in terms of managing and preventing, I consider two categories. And the first one is where the condition is well documented by the physician, okay? And that means that I think the payer made a mistake and that it was clearly valid, and I appeal those, but I also often escalate them, and that escalation may be to our revenue cycle, who has a liaison with the payer, or it may be directly with contracting to say, listen, we need to write something in our managed care contracts that prevent this from happening. And then, of course, the second category under valid is lacking documentation by the physician. Okay, so this may be that we're lacking supporting documentation. It may be that there's some conflicting documentation. It may not be documented consistently. Whatever the case may be, again, if it's valid, I appeal, but then I use this as an opportunity to educate both our physician staff and our CDI. And then within this distribution, we track the proportion of valid claims appealed in addition to the overturn rate. Okay, so this is kind of the return on investment for putting efforts toward this process, right? So if I can't cover all of the valid claims, I can begin to show the return on investment and hopefully get more help to do that. And, that's important, because if you don't fight these, the payer is going to keep sending them. But once you start fighting the ones, especially that are well documented, it takes up their time also to be in this process. And I find that they tend to leave those alone. Okay, so we're going to go on to the appeal process in general, and I'm going to launch the next polling question, so go ahead and put that up there. And the question is, what resource does your facility utilize to appeal clinical validation denials? Is that the internal coding team, an internal nursing clinical team, a combination of internal coding and clinical resources? Do you outsource, or are you unsure? And Sarah, while we're letting those answers kind of flow in, what resources does St. Luke's tap into to effectively manage these denials, and has it evolved over time?
It definitely has evolved over time. When we initially began receiving clinical validation denials, my my DRG coordinator, coding guru, was trying to appeal them with, a limited Google search of clinical criteria to support a specific, condition, a diagnosis that was being denied. And with little success. Obviously, she doesn't have that knowledge, nor should she be responsible for those type of denials. So we then started utilizing our CDI team. They've got that knowledge there. It also, in turn, utilizing them for these denials also helped to improve their understanding of some of the clinical conditions and what they should be looking for in the record to help support these diagnosis codes as well, and would also help spur what types of queries they should be providing or sending to the providers if a diagnosis was not supported clinically. And then we also have started using our physicians. We did have a physician that said he would be willing to help us with some of these clinical denials, and so we are utilizing him anytime that we just really aren't sure or are on the fence. And we also are looking to potentially start using an outside vendor to help with some of the clinical denials as well. We haven't implemented that process yet. We're still all doing everything internally, but it has evolved over time.
Yeah, that's excellent. You know, I think within our hospital system, we have our main coder who works them initially and taps into our second level review and our CDI manager, and then typically they come to me. And, you know, one of the things that we've not necessarily involved is the day-to-day, you know, CDI and the chart. And so to kind of mitigate that knowledge gap, you know, I've started to attempt to sort of hold specific meetings over specific topics like sepsis to show them what we're seeing. But I think that's vitally important, really, to be able to craft these validation queries. Do we have some results?
We do, and really quickly before we dive into those, I did want to share a couple of the other diagnoses that you'd requested. We did get a few of those in the chat feature. So several responded with respiratory failure, several referred to acute kidney injury, a couple with pneumonia. Anyway, thought that may be of interest to you. So looking at this poll specifically, the results came in. It looks like 13% responded internal coding team, 12% responded internal nursing or clinical team. By far the largest response was 58% with combination of internal coding and clinical resources. 5% responded outsourced and 13% were unsure.
I actually am pleased with those results. I think that having the highest be a combination of internal coding and clinical resources makes the most sense, because again, sometimes, you know, it comes down to a present on admission or a coding rule, and I, as the clinical resource, don't necessarily pick up on that. So again, I think that combination is great. All right. So looking at the appeal process step by step, and now we're going to kind of, you know, hone it down into the granularity of what your coding and CDI teams are really doing in terms of their role. And so again, my process is always to start with reading the letter and highlighting exactly what's being denied and why. I've been burned on this, where I've gone down a rabbit hole and I've started answering questions that really the payer was not confronting. And so again, just understand what's being denied. I then go and I critique the payer's cited references, right? Because whatever criteria they're using, they need to be backing it up with national guidelines and scientific papers. And that is going to be potentially a basis for my argument in the appeal. If you have institutional definitions, I keep those pulled up on one computer screen. And as I'm working through the chart to determine whether I have a legitimate case, I'm referencing back to institutional or standardized guidelines. So you say, how do you assess legitimacy? And you know, it's not fancy. It's simply starting at the beginning and reading through the chart like a book. So, you know, I go back to the EMS or nursing home reports, certainly the ED, look at how they transitioned in, and then follow that story all along. And I do jot notes about supporting and non-supporting documentation. Specifically, I try to find something that was not made available to the auditor initially, because that's usually part of their statement, right? What was sent to me did not seem to support it. So, you know, I go back and I look at prior encounter records. You know, I use everything at my resource to argue that this diagnosis was accurate, even things that you know, may not have been included in a query. Pre-hospital records, as I mentioned, the ED notes, nursing and ancillary notes can often be very helpful in tracking, you know, mental status on an encephalopathy patient. And occasionally I have to contact a clinician and say, hey, you know, I don't see it. You know, if you remember this case, can you provide some additional insight? So this is our standard clinical validation workflow. And, you know, I actually use it and our staff uses it to validate concurrently, but I also use it when I'm working the appeals, because it helps me craft whether or not I think that this diagnosis is valid or not, but it concisely and completely puts things in perspective. And whether I'm writing a validation query or arguing an appeal, I can articulate what I want to. So the first question is, are minimum diagnostic threshold criteria met, and are there exceptions to the rule? The second question is, does the evaluation and management match the diagnoses? Now, again, treatment does not define a diagnosis in almost 99% of the cases. So again, it's not imperative, but it does help me get a sense of the big picture. So did the patient bolus, fluid for a septic patient? If they did not, did they tell me why they didn't? And if they didn't do either of those things, I'm kind of questioning, did they really think the patient had sepsis? The third question I ask is, if there's contradicting documentation, is it insignificant or has it been addressed? And this is the toughest one, I think, because whether or not it's insignificant kind of depends on how strong all the other support is. So this is the part I think we find the hardest. Is it documented consistently? Okay, so again, I think that that's part of the coding guidelines, but also part of telling that story. If you only mention sepsis in the first chapter and you never bring it up again, I mean, how important was it? Was it really a main character? And then the last question is provider rationale documented? And again, if it's a slam dunk and it's completely obvious to everyone that this patient is intubated, they don't have to lay it out for me for acute respiratory failure. But if it's diagnosed after the fact, or if the patient was only put on 2 liters, or if they were never really short of breath, I need to see more from that diagnosing physician on what picture was in their head that didn't make it to the paper. So I'm going to ask Sarah another question here, because I think this is important, and it's one that I had for our CDI manager, which, as we embarked on this process, what proportion of your overall queries were validation queries? And if there was fluctuations or if it was high or low, what do you think contributed to that?
We have about an 8% rate of clinical validation queries that we're sending. Sepsis is our number 1 clinical validation query we are sending, but overall, and they're about 4% of that 8%. Yes, we do see fluctuations in the numbers. Anytime we have a big group of new physicians start, we see an increase in the number of clinical validations we're happen to send. In July, for example, when all of our new residents start, we have to go educate them on the criteria that St. Luke's Health System has agreed upon to use, for sepsis, for acute respiratory failure, for type 2 MIs, encephalopathy, and so on and so forth, to help them to understand that they can't just simply document the diagnosis in the record, that the clinical criteria has to be there to support it. And then we've also seen with our EHR that we use, there's lots of little shortcuts that can be created within the system, or triggers within the system that we have to alert the provider that a patient might have a specific condition. And anytime any of those new triggers are created within the system without CDI's input, we do see an increase in the number of clinical validation queries we're having to see, because the system will trigger the provider, hey, we think this patient might have this condition based off of, these lab values and other vital signs that are available in the record. Do you think the patient might have this condition? And the doctors, without thinking about it, sometimes will just add the diagnosis to the documentation. And so then we have to go back and we have to, send a clinical validation query for that. Generally, though, our IT team, our clinical informatics team, is really good about including the CDI team in those conversations before they implement those types of triggers within our EHR.
Yeah, sorry, you made me think of a topic with regards to sepsis. And, I think that every time we have a big educational push about casting a wide net, we see the ED doctors documenting it a lot and then it not being mentioned again. And so we're having to, just validate that it was not present or, get it documented in the record. So again, that brings up our electronic health record challenges sometimes. So that was a great point. Okay, so you've answered, do you have a legitimate case? And I can't stress this enough. If it's not valid, pay it back. If it is valid, appeal it. And again, know your contract rules with the payers and engage those experts as appropriate. And then again, standardizing this appeal process will help identify preventative strategies. And so we're going to go through a couple examples of how we've looked at prevention and how that's kind of helped us hardwire our processes. And, it's really identifying where your gaps are. And to do that, we really had to be looking at first our payer denial patterns. And, again, I think we've already mentioned they're going to target those diagnoses that, when removed, results in reduced payments. So it may be removal, it may be present on admission and a principal diagnosis. I've even had them come after complications so that they're not a principal diagnosis. So again, they're going to be looking for things that reduce payment. The second thing we see oftentimes is this vague rationale. So again, the condition was not consistently documented and or there was insufficient supporting documentation. So, this personally frustrates me. Which is it, right? So, clearly I know I'm getting some sort of form letter, and those are a little bit harder to tease out. The next thing is diagnostic criteria. And, probably the one that I see the most now is where they include treatment as a condition for validity, whether that's TPN for malnutrition, whether it's BiPAP for respiratory failure. They're including that as part of their definition. And again, oftentimes that's not appropriate. We're seeing them combine guidelines. And so for those of you in the 61% of sepsis, I'm starting to see them quote, sepsis 2 and sepsis 3. And so it becomes confusing. And, those often I take peer-to-peer because I need to get more definitive answers. Incorrect facts have been quoted. Inappropriate application of the definition. I think I've seen this where they tell me that, COPD patients are hypoxic all the time. That's not true. If they're hypoxic, they have chronic respiratory failure. They do that in order to debunk the acute respiratory failure that the physician has documented. Sarah, I don't know if you have any other examples in this diagnostic criteria section.
Yeah, well, we've seen where the same payer will use, for example, malnutrition. They will use Aspen criteria if it fits the need. But if it doesn't, then they'll use the GLIM criteria. That is a trend that we've seen, that they will change what they're using as their criteria to fit their intent.
One of the things Sarah and I were talking about, I think, Sarah, you told me you got a recent denial on sepsis where they denied it, not because the patient didn't meet sepsis, but because the physician didn't do the math on the SOFA score. That's the kind of stuff that just tips me over the edge. And of course you would fight that.
That's a great example. So the payer acknowledged that, the patient met the SOFA 3 criteria, or the sepsis 3 SOFA criteria, but the doctor didn't do the math and document it in his notes. So they weren't going to pay us for the patient having sepsis.
And of course, that's not part of the definition. So you would certainly want to appeal that if you start getting those at your facility. I look at the references. Sometimes they're outdated or not relevant. And then, this cloning. I mean, we think of cloning as something we do, in our record. But again, sometimes they send the same letter even after I've written an appeal and added more information. So again, just call them out on that. In terms of physician documentation patterns, I think we're pretty familiar with this, using inconsistent language, two diagnoses interchangeably. Insufficiency and failure is the one I think about most often. conflicting or unclear documentation, so using a slash or contradicting exam findings. I've seen and heard of some pretty wild things on this. Sarah, do you have any examples for that one?
I can't think of anything off of the top of my head at this point, but I am sure we have experiences. I am absolutely sure.
I mean, one of the things, and obviously patients who have delirium can be awake and alert one moment and, hallucinating the next. But, that well-nourished and malnourished, I think, has come up, although I've seen less of that since we've started fighting those if a patient clearly needs severe malnutrition.
Yeah, Beth, my apologies here. I was stuck on point number 1 and not point number 2 there. Yes, we have absolutely seen this, especially with encephalopathy, where they've said the patient is alert and oriented, but then we've got a documentation of encephalopathy, or the patient looks well nourished, but we've got documentation of malnutrition. Those are definitely some opportunities we found internally at my organization.
And, I'll just go back to, kind of the validation query piece of it. If something like that is contradicting, but everything else supports the diagnosis, we don't always lob out another query out of respect for physician time. But if it's borderline, the insurance company is going to pick up on that and run with it. So the other thing we see is really an adequate description of the thought process. And this is mostly called out when atypical threshold criteria are used or we're introducing the diagnoses after the fact. And we encourage our physicians to do that. We often don't always put the pieces together the minute they hit the door. But if you do add sepsis on day 3 and tell me it's present on admission, you might have to put the pieces together for me. And then, here, only mentioned once. So again, that main character, and not in the discharge summary. And again, we know the guidelines tell us that we can take from documentation anywhere in the chart, but if we don't feel it's important enough to put in the discharge summary, the payer is going to say, well, was it legitimate? And I'm going to kind of ask Sarah a little bit about her process around discharge summaries, because I thought this was interesting and unique.
Yeah, we have seen a number of trends where they have denied it based solely off the documentation was not present in the discharge summary. So the doctor could have done a fantastic job of documenting in the H&P throughout the progress notes, and maybe the condition resolved, especially if it's one of those really long lengths of stay, and the condition resolved, and so they didn't put it in their discharge summary because we all know there's some limitations with the EHR. On how things get resolved within your EHR. And we have seen denials where they are specifically just saying, yeah, well, it's not in the discharge summary, so the patient didn't have it. The physician did not feel that it was clinically significant, and so we don't feel that it is supported. So we have started, the CDI team will do a post-discharge review, as well as the coding team. So if CDI has not reviewed the account, the coders will do it as well. But if it is the lone CC or MCC on an account and it is not documented within the discharge summary, we will query the provider to provide the clinical significance of that diagnosis and validate that it truly was clinically significant. So if we do happen to receive a denial from the payer, we have the provider's response that supports that the diagnosis in question was clinically significant.
So I'm going to reiterate the main point of that. It isn't just asking, are you sure this is a diagnosis? And the doctor saying, yes, they had acute respiratory failure. You're specifically writing a query that, addresses, was it clinically significant? And so I think, that's important, again, because of the message that's sent when it's not in the discharge summary. So that's great, Sarah. Okay. Our last piece of the puzzle is really looking internally, okay, looking at ourselves, which oftentimes is the most difficult thing to do, is kind of that 360 critique. But it's important, and I think one of the most obvious things is clinical definitions and our diverse interpretations of the threshold criteria. And when they don't exist, it's certainly diverse. And even when they do exist, we find that CDI look at things a little bit differently and somewhat inconsistently, and that sends a mixed message to the clinician. The second thing we look at is our queries, both regular queries and validation queries, meaning when we're asking for a diagnosis. There's variable inclusion of supporting and conflicting clinical indicators, right? So we're responsible for presenting that unbiased picture to the doctor to make their assessment. The clarity of the question, concise yet thorough, right? We want our physician documentation to be that way, and we have to have our queries be that way. And much like sending out emails, text messages, once you write it, it's good to do another read through to make sure that you've taken out anything that doesn't need to be there and you've included all the important points. The exclusion of clinical significance. We're not going to go through example queries in this webcast, but I think, tailoring your clinical significance. So if you're writing a validation query for severe malnutrition and they didn't receive TPN or they didn't receive tube feedings, or maybe they're not even getting, aggressive oral supplements, asking how is the malnutrition impacting care? If they have a pressure ulcer, if they, have muscle weakness, putting those as possible answers as long as they're supported with the evidence. And then coding. And, I think there is variable application of the coding guidelines. We like to believe that they're black and white, but I think that we all interpret consistently documented a little bit differently. And also kind of our definition of what a secondary diagnosis is. Again, that monitoring, treated, evaluated, increased nursing care, or length of stay. And Sarah, you're in such a unique position kind of leading both CDI and coders. Have you seen other patterns come to light as you manage the denial process at St. Luke's?
Well, one of the biggest trends that I've seen internally is the increase in the number of clinical validation queries that we're sending. And that's just due to us. The CDI team has worked very closely with our providers to define or set clinical parameters for those diagnosis codes that we are seeing commonly denied by the payers. And we set the clinical parameters with our providers, and the CDI team uses that pretty religiously to, when they see one of those conditions documented in the medical record, they validate that the condition is truly supported clinically, it is treated or assessed or monitored, and if not, then they will query the providers. So we have seen a trend in the increase of those types of queries that we're having to send, but that's okay because we're making sure that the record is accurate and supports, what we're going to be putting on the claim. And we've also seen an increase in the amount of education that we're doing to our providers because, it's kind of, they're clinical and you expect them to be the experts, and they absolutely are the experts. But what we have found, they all kind of have a slightly different variation in their definition of what a specific condition is. And so just getting them all on board with this is what St. Luke's Health System is utilizing to define this specific, diagnosis.
Yeah, that may have reminded me, our first diagnosis to tackle about 5 years ago was acute respiratory failure, and we had a physician who saw a lot of COPD exacerbation, and oftentimes their oxygen increase wouldn't be significant, and we would query him, and he finally got used to telling us that, hey, this is really, a potentially life-threatening process for them because I normally treat them as an outpatient, and I felt like they needed to come in for these reasons. So again, it's not that everyone has to conform, but they have to make a compelling argument that their criteria are relevant for these high-value diagnoses. Okay, so in summary, again, classify your denials. Are they valid, not valid, or are they lacking documentation? Appeal every valid diagnosis if you can. Hold payers accountable for the accuracy of their denials. Again, they are doing their job. We should not be submitting claims that do not have supported diagnoses, but if they're overshooting or they're being inappropriate, we need to call them out for that. Track your successes and your failures, okay? The successes tout your return on investment, and the failures are a teaching tool. Again, we talked about the vulnerabilities. I think you really need to go through each of these 4 aspects to kind of personalize those. And then lastly, and I know I mentioned this with the CDI, but you have to provide feedback. I mean, people don't know that they're creating downstream problems unless you tell them. And sometimes they come back with better solutions than you have because they're in the trenches. With that, I think that we'll see if we can get some questions.
Okay, thanks to both of you. Dr. Wolf and Sarah, that was a great presentation. I think a lot of valuable information, had a lot of engagement, a lot of questions coming in already. But for those of you who haven't and would like to submit a question, you can do so using the questions feature on your dashboard. It should be at the right side of your screen. So as you're entering those, I did want to share a couple of other items that are upcoming and that we wanted to talk with you all about. If we advance to slide 1, perfect. So as most of you probably know, CMS has introduced some pretty significant changes coming to the E&M coding guidelines. These are important things for anyone who's dealing with E&M coding to be aware of. So we've put together a 4-part series, an educational series that we'll be offering. That'll be available August 31st. In total, it'll be 2.5 hours. It's pre-approved for CEUs through the AAPC, or you can get a certificate of attendance that you could submit to the organization of your choice to seek CEUs. Those who do purchase the series will also gain access to a physician pocket card that'll be available on September 15th. So the items that we'll be covering, as you can see on the left side there, we've got 4 different modules covering the E&M revisions for 2021. How did we arrive here? Decoding medical decision making, talking time redefined, capturing the true work involved, and the last one is implementing the revisions, developing your action plan. So really a comprehensive course on the E&M changes for 2021. And you can use the link below. You can either type that into your browser, or as you get the handouts after this, you can click on that link and jump in. So hopefully everybody will take a chance to explore that. On the next slide, we wanted to allow those of you who have interest in some of these solutions or services that deal with some of today's topics, you can express your interest here and we can send some follow-up information. So with 3M Advanced CDI Services, that really is a comprehensive approach to building and improving a CDI program that we know can have a significant impact on a lot of this denials work that we've been talking about. We also have the 3M quality services that really identify and address the root cause of quality performance issues. So those are really focused on quality. That's a great service that 3M offers. On the technology side, the 3M 360 Encompass system for CDI encoding really is a platform or a system that unites coders, CDI specialists, and management. And lastly, the last one you have there is our 3M COVID-19 webinar series. Obviously, we continue to be in the midst of a very unique and kind of unprecedented pandemic. So those webinars are designed to help explore the implications for coding, CDI, documentation. So we invite all of you to explore those if that's an area of interest. So with that, I think we're ready to jump into some of these questions. So they are coming in fast and many. So let me sort through these really quickly and see if we can get to a couple.
Yeah, while you're looking through those,
yeah,
just know if we don't, for those of you listening, if we don't get a chance to answer them in the last 4 minutes here, I will take a look at each one of them and reply out.
Absolutely. Yeah, so we'll get those. We'll get responses out via email. So thanks to both of you for doing that. So the first one, we'll go with a quick one from Dana. It says, do your coders send clinical validation queries?
Well,
Sarah?
they aren't They are not supposed to. The CDI team is supposed to be sending them even after the fact if the coder determines that a CV query should be sent, just so that CDI can include all of the clinical criteria in the query. But we do have templates built. But we do have some very, very good coders that have been doing, have been coding for a really long time, and they will actually go ahead and send the CV queries themselves.
And Sarah, I would say also about 2 years ago, we really negotiated a process where the coder would kick those back either to the CDI who reviewed it, or if it was not reviewed by CDI, to our second level reviewer.
Yeah, that's generally our process as well. For the most part, I have just a handful that they feel very comfortable doing it, and I feel comfortable with them doing it as well. So, we make some exceptions here and there.
And I would just reiterate, it's not that they can't do it, it's that it's very time consuming. And our coders, right. Not that our CDI aren't under pressure, but I mean, there is a lot more monitoring of their productivity in that regard.
Right. Yes.
Okay, great. Thank you. And thank you for the question. The next one comes from David. He says, how do you address providers using SIRS sepsis criteria when revenue integrity companies using SOFA sepsis criteria deny your sepsis diagnoses?
So at St. Luke's, our organization has continued to use the sepsis 2 criteria, and so our doctors, that's what they're using to diagnose the patient with sepsis. If the patient met the sepsis 2 criteria and we get a denial for the SOFA criteria, we're still appealing it because we are internally using that sepsis 2 criteria. And oftentimes we can find in the record when the patient met sepsis 2, they also met SOFA criteria. If you actually go through the record and comb through it, they usually will also meet the SOFA criteria. You just need to look for it and include that in your appeal letter also.
Sarah, very similar for us. We are still using sepsis 2, but the details of that article really state that the findings have to be over and above what would be seen in localized infection. And so if really the only thing we find is, the heart rate, the respiratory rate, the temp, and the specific and the white count, we do post a validation query that has the physician attest to the fact that it was over and above what will be seen in localized infection. Before we do that, though, we are looking at the O2 sat. Again, a sat of 94% on room air is 1 SOFA point if they have normal lungs. Okay, so again, and if they have cellulitis, again, you can kind of look through and find some organ dysfunction, even if the physician doesn't pull it into their note.
Excellent, thank you. A quick one for Sarah. This comes from Sherry. Just was curious how many CDI staff you have, Sarah. It sounds like her staff are super busy with reviews and denials, and they only have 3.
Yeah, I actually have 14. So they are definitely busy with reviews and denials and sending queries, but I do have 14 across my facilities. We obviously don't do CDI at the critical access hospitals. We've also got a psych facility, so we don't do CDI there as well. And we've got a couple of rehab facilities where we don't utilize the CDI team. So the core group of my CDI staff of the 14 are at 4 of my facilities.
Excellent, thanks. The next one comes from Kelly. It says, how many denials do you find that you need to escalate in the appeal process to peer-to-peer review?
So I'll field that one. I would say that I take 25 to 30% to a peer review. Most of our payers, the contract requires that you write 2 appeal letters and then request a peer-to-peer. So again, they're not all the same. But I have found that if it's valid and I, am willing to stand on that hill, I do it. Now, I will say when I first started, I would only take ones that were absolutely positively, 100% valid and it was clear. I do live in a little bit more gray now because I feel like when you take it peer-to-peer, if I have 3 cases to argue with another physician, they're more likely to give me the 2 that I know I should get if I can give, 1 back in the gray area. A little bit of psychology that I learned along the way. Probably of all the ones that get sent to me, I win maybe 50%, and the other 50%, I take peer-to-peer. Of course, that's probably only represents about half of all the clinical validation denials. Many of them, the coder writes and wins, or, we pay back because they really don't appear to be valid.
Great, thank you. And apologies, like I said, there are a lot more really strong questions in here that I think would be valuable to cover, but we are out of time. So we'll address those via email. Thank you all for jumping in and submitting those. As we wrap up, we want to remind you, please take a couple minutes and complete that survey that will launch at the end of the webinar. Also, the registration is open for the September quality webinar. We'll be exploring value-based purchasing models. So just as you signed up for this one, jump in and register for September's. And last reminder that the recorded version of today's presentation and webinar will be available on the archive on our website, along with the PDF of the slides, and a certificate of attendance for all webinar attendees will be sent to you at the completion of the webinar. So Beth and Sarah, thank you for this excellent presentation. Thank you all for joining us. We hope you have a great rest of your day and look forward to seeing you next month. Take care.